And now we're going to hear from Uwe Reinhardt, who may have some different ideas. And again, we like to have all the ideas out there. So now it's my pleasure to introduce Uwe Reinhardt, who is the James Madison Professor of Political Economy at Princeton University. He's recognized as one of the nation's leading authorities on healthcare economics. He has served on numerous prestigious commissions, advisory boards, and editorial boards. And you can see more about his background in the packets if you look at his bio. He's a prolific author and an original thinker, with a gift of making rigorous, complex economic analysis accessible to his students and to all of us here. He informs public policy and the public as a frequent speaker and blogger for the New York Times, Forbes, and JAMA, and talk about a wide range of outlets there. He's NIHCM's longest-serving advisory board member, and I've actually had the pleasure of working with him for over 22 years. So it's a warm welcome that I offer to Uwe Reinhardt.
Well, thank you, Nancy, for this nice introduction. And Nancy called me and says she likes to have a skunk in the garden party at every one of these meetings. And I said, that's why God created me. So here I am. Are my slides up? Oh, yeah, I can see them. So what do I do with this? Yeah. Okay. So if you think about innovation in healthcare, there are really two areas. One is biomedical research, the one Ovik was just talking about. And the other one I would call operations research. Every industry has that. In our field, we call it health services research, which is aimed at improving the efficiency and patient safety with which healthcare is delivered, including drugs are delivered. And these are quite different areas. On the biomedical side, the advances have been breathtaking. Ovik says there could be even more breathtaking. We could have more yet of them. A Viagra pill lasts 50 years, say, for example, or something like that. But the reason we are the leaders, and the U.S. is the leader in this field, is we have great scientists, and if we don't grow them, we just import them. We have a flourishing venture capital market, such as no other country has. And every year we spend tons and tons of money on supporting this particular kind of research, both public money, NIH, roughly 50 billion, and private even more so. When it comes to operations research, that's the stepchild of, which is amazing to me. Very few industries would spend close to $3 trillion a year and spend as little on operation research as we do in healthcare. As I said, total federal spending on research in healthcare is about 50 billion. 2 billion, these numbers come from Academy Health, which is the Association for Health Services Researchers. 2 billion is on health services research. That's 0.07% of total national health spending, or in plainer English, for every $10,000 of national health spending, $7 on operations research. Not a lot. And then, in general, we have paid for this, because if you look at the publications that came forth from the Institute of Medicine over the years, To Err is Human, Crossing the Quality Chasm, and many others, we spend a lot of money, roughly, with the exception of Switzerland, twice as much as most other industrialized nations per capita. But everyone now agrees, while American healthcare can be splendid, overall we don't get our money's worth. That's now generally agreed. So Congress, I think, has just allocated a pittance to operation research, and I don't quite understand why that is so. The private sector has underinvested too, but there is a theory of public goods. Everyone who had Econ 101 knows it. And that is, if I spend money on something and the benefits accrue to others, who didn't spend money on it, I will underinvest in that activity. And so that doesn't mean private industry is evil. They just own up to the theories we teach in Econ 101, which is nice. And it gets worse. It took us years to establish the Agency for Healthcare Quality Research. I was one of the actors trying to get that established, to get operations research, particularly patient safety and quality, into healthcare. And yet, of recent, there has been talk at some point to zero out the budget of that agency, or at least to cut its budget drastically. I think that is just penny-wise and pound foolish to do this. And that agency gets about $400 million a year, which is 1.016% or $1.60 for every $10,000 national health spending. Now, if you think that that'll solve the deficit problem Ovik was talking about, I have news for you. But that's really a shame. Sometimes you get the impression as if Congress is actually encouraging inefficiency, or at least doesn't care about it. And they should. They should care about it, because healthcare is breaking the nation's back. So Congress might pay some attention to the efficiency, but also to patient safety. Now, this morning at breakfast in the Financial Times, I saw Gillian Tett had this thing, a revolution is underway in U.S. medical services. And when you have gray hair like me, you've heard these revolutions many, many times. I had a slide that I decided not to use. Oh, yeah. It's a thing that says bullshine protector that you put on at these conferences, because I've heard this now for 30 years. I think there will be progress, obviously, in the use of IT and all the little startups. Some of them will pay off. But the progress in this field will be much slower for a whole number of reasons. This I've already said. I've heard Microsoft and Google and others, they nibble at the fringes of this problem, but I've heard them for at least 10 years, and I have yet to see the major fruits of that coming. So the word is not revolution, it's evolution, which does not, however, mean we should discourage it. There are going to be many good ideas. The problem always has been scaling up. We heard some wonderful presentations now from Massachusetts and from Florida. And the question is how they will succeed, I would hope. Will it scale up nationally? And the reason I say that, again, you say, why do you always say this? Well, 70 years ago, we invented a wonderful thing in America. It was called Kaiser, right? Kaiser, the Kaiser Permanente health thing. I still personally believe that is the way healthcare should be delivered. It never scaled up. So we now reinvented a bastardized, weaker version of it called Accountable Care Organization. If they succeed, they'll slouch towards Kaiser, but half of them will die. So since we already invented the good thing, why do we have to reinvent something less good? I just don't get it. But I'm just an immigrant. Maybe I haven't told you. So, but there are other reasons also. Very often the innovations in this, in operations research and healthcare delivery, they're changed, they're disruptive. I always say Clayton Christensen says disruptive innovation as if it were a good thing, not if I'm the guy whose life gets disrupted. So therefore there's going to be resistance to a lot of these things. And we should always remember one person's efficiency is another person's income loss. That happens, and so I shouldn't wonder if K Street is populated with people who devote their life to perpetuating inefficiency in American healthcare because they're paid to do that. So for all those reasons, this is not easily done. Now, let me say a few words. I had to obviously disagree with Ovik. It's another reason I was born. First of all, I will agree with him. Getting a pharmaceutical product to market is a lot more difficult than most people realize. You really have to run the gauntlet. I have it here. It's not my design. Somebody else. You start thinking of a theory or of a compound, which is called a preclinical. Then it's phase 1, where they try it on humans just to see if it's safe. These are volunteers who do that. Phase 2, they look at efficacy. Does it actually do some biological thing that it's supposed to do? And the third phase is effectiveness, means if that were applied in practice with patient compliance or non-compliance, et cetera, would that actually be effective? And then you make an application for approval, and that takes many, many months, sometimes years, and finally a drug succeeds. But at every stage, the bulk of them die. At every stage. So it's been estimated out of 10,000 tries that get started, 1 or 2 make it to the end, So that has to be understood. And as Ove correctly says, you have to add to the cost of a drug that makes it all the cost of the failures, of the dry holes in the oil industry, we would call it, that we had along the way. And you have to add to it the opportunity cost of the money, the finances that you sunk into it. To an economist, that's as real a cost. So if I could earn X% by putting my money into high-button boots or anything else, and I put it into drug development, I must at least get compensated for the money I didn't make, putting my finances into some other thing. So therefore, the billion-dollar price tag, 2.6, one could argue about it, but sort of that many drugs cost between $1 to $2 billion to develop, I believe that. I think that's easily demonstrated. So that much is true. The interesting thing is, one reason that drives healthcare costs is we are extremely finicky when it comes to drug about side effects or killing people. Very finicky. Drug and devices are held to very excruciating standards, more in the US than in other countries. Remarkably, though, when it comes to other areas of healthcare, hospitals say, we've been much more relaxed. This is 1999, where the Institute of Medicine came out with a study that said anywhere between 50 to 100,000 patients die prematurely in American hospitals from avoidable errors. Now imagine if a drug killed that many people. All hell would break loose. Here's a later study that's just out 2013. It says 400,000 patients die every year from avoidable error. And that's from the abstract here. That's what it says. I'm just telling you, I'm not making this up. So why do we have this strange attitude with the hospital to say, yeah, it's too bad. I wish I weren't there, but... And then for the drug industry, it kills 5 people and all hell breaks loose, and it's on the evening news. I don't quite understand that. So there's many things in life I don't understand. The other thing I don't understand is why Hawaii has an interstate highway, if anyone can tell me that. But let me now talk a little bit about the pricing. So the pricing, because we're producing drugs with investor-owned companies, with venture capitalists, those tough people who are in there, we tend to think of the pharmaceutical industry as the quintessential examples of private enterprise. I have a different view of it, and here's my view. That's the drug industry. It sits in the protective hands of government. Like no other, very few other industries have to do that, other than those with intellectual property. What are those protections that it gets? Not only the NIH money, where tons of money is spent for research pharma can use, But patents, market exclusivity, if a patent runs out, the FDA can give you more years of market exclusivity. Data exclusivity, which means a generic company cannot use your data, the brand name company's data, to do research. Prohibition of resale of drugs among customers, like we can't go to Canada with a truck and buy stuff there, and there are sundry other subsidies. So it's a highly protected industry. And when you have that little bird in the hand, sometimes the government says, I want you to chirp a certain way. Well, you better do that, right? Because you could have price controls. Now, price controls for drugs is going to be very difficult. I mean, I wouldn't want to be on such a panel because there are really no cost to hang your prices on. That would be very complicated. But you could, before coming to that, I want to say the industry now talks about value pricing. They say, well, you know, yes, our prices are not set on cost. Incidentally, I should say, no one's prices, no industry price is ever set on cost. If they happen to be equal cost, that's accidental, that's in a competitive market, but you don't price on cost. You always price on what the market will bear. Cars are that way, Diet Coke is that way, everything is that way. And drugs, of course, are that way too. And they call it value pricing. The problem here is when it involves human life, what is the value of a quality-adjusted life year that we could buy with drugs for some American? We don't know that. If I were to ask you, can you write that down for me? Is it 100,000, 200, a million? We are too shy to even discuss it. And the drug industries, they can then say, well, let's just see how high it is, till they say no. And we never say no, because the minute I say no at $150,000, then I know that's the maximum price I put on human life, and I look like a fascist. So therefore, this is a very difficult thing to do. But what could be done, you could, for example, when a price looks just unreasonable on its face, this is not price control, but when it really seems unreasonable, say, all right, you can do this, but we'll cut your market exclusivity. We nibble away at this, or data exclusivity, or what other benefit and protection we give you, we'll take that away. That's not price controls as such, but it simply says it's a Damocles sword to say if you're too unreasonable with your price, then we have these other methods. And I want to give credit to Len Nichols. He wrote it in the paper before I thought of it, so he should get the credit. There is, of course, the question, we want to reward risk-taking in America. Everyone, and drug company investors take risks. There's no question about it. The right amount of risk premium we want to pay investors in pharmaceutical enterprises is the amount that would give us the right flow, the desired flow of innovation. That's what we'd like to do. In real life, that's very hard to do, right? So I was sort of thinking loosely, as I sometimes do, to say, well, there are other people who take risks for us. Firefighters, police, the military, they take enormous risks. What risk premium do we give them for that as a benchmark? And then say, well, what do you need to do something for America, something good? These guys fight for us, fight ISIS. Well, you fight little bugs called bacteria or viruses or whatnot. What do you need to do something for America? And if you look at it that way, then sometimes you say, you know, the risk premium we have been paying the drug industry ain't bad. It's really quite good. This is a Humvee. That's what it looks like when it hits a road mine. You know, and we ask young people, go drive this thing and take this chance. What do we pay you for this? So I say, you know, you don't always need a boat or a jet or something to develop new drugs for us. Let's reason this out we want you to have a good rate of return, to be sure, but the sky shouldn't be the limit, because healthcare has opportunity cost, among them educating our kids, and so on and so forth. Finally, it is not uncommon to be with people, and I've been with these people, who will tell you they defend the high prices of the drug industry. They say, they argue for even more protection for the industry. They argue for cuts in social spending and lowering taxes. And they do that all in one breath. I've literally been on panel with people like that without connecting the dots. If you want everyone to have Harvoni and Solvati, that'll increase social spending. I mean, you don't need a PhD to understand that. You know? And that brings to mind a theory that was developed at Princeton. It's an astronomical theory, and it says this: the strongest proof that there is intelligent life elsewhere in the universe is that it has never tried to contact us. Thank you very much.